All right, my name is Tuscan Butardo. It's my pleasure to serve as your moderator for this evening's Miracle of Life series. I'm honored not only to serve as tonight's moderator, but to also work here at Torrance Memorial for the last 11 years. I currently serve as one of the lead RNs in our burn intensive care unit, alongside our incredible team of physicians, nurses, and interdisciplinary staff. I'm also a proud member of our burn outreach team with Dr. Murthy, where we actively provide burn prevention and education to the hospitals, local communities, and schools. We actually have one of our tables outside with Casey and Momo manning the team. I'd also like to recognize Mary Ford. Hey, Mary. Mary, come back, Mary. She just stepped out because she is running around making sure this event, there she is. Hi, Mary. Just wanted to recognize Mary Ford, who's been instrumental in organizing tonight's event and primarily responsible for everything that you guys see going on here. So let's give her a round of applause. All right, on behalf of Torrance Memorial Medical Center, thank you for joining us. Whether you're here in person or joining us in Zoom, virtually, we truly appreciate you taking time to invest in your health and the health of our community. Now, the Miracle of Lecture Series is dedicated to empowering our South Bay community through education by providing practical knowledge that helps people live healthier and safer lives. Tonight's presentation is titled Caring the Skin You're In: Burns, Sunburns, and Skin Cancer. Your skin is your body's largest organ and our first line of defense. Understanding how to prevent injuries, recognize warning signs of skin cancer, and knowing what to do in burn emergencies can make a life-changing difference for you or your loved ones. Now, before we begin, I hope everyone had the opportunity to take advantage of our complimentary health screenings outside, including blood pressure, BMI, and our carotid artery ultrasound. Now, before we get to our speakers, I'd like to go over a few housekeeping items. First and foremost, please make sure to silence your cell phones and your phones right now if you have the time, to minimize interruptions during the presentations and out of respect for our speakers. If you need to step out at any time, please feel free to exit through the double doors. The restrooms are also located through the double doors to your right. Now, each speaker will have about 20 to 25 minutes to speak. We kindly ask that you hold all the questions until they're finished with both presentations. And then during the Q&A, along with Frank, who will be assisting me with the mic, I'll be facilitating the discussion with our speakers. Now, if you have a question during either presentation, please let one of our wonderful committee members know. They'll collect your question and forward it to me, and I can get it through here directly on the screen, through the chat virtually as well. And then we'll be happy to follow up any questions today. And if we're unable to answer any of the questions this evening, please see one of our members or Mary Ford after the program, and we'll be happy to follow up via email if we can't get to it tonight. Now that we've covered all the housekeeping items, it's my honor to introduce our distinguished panel of experts tonight, beginning with Dr. Marcin Dragan, followed by Dr. Murthy, who will be speaking. Our first speaker, Dr. Marcin Dragan, is a board-certified oncologist, hematologist, and internist. Dr. Dragan earned his medical degree from Jagiellonian University Medical College in Poland and completed his internal medicine residency in Virginia Commonwealth University and went to complete his hematology oncology fellowship at Harbor UCLA Medical Center. He specializes in the diagnosis and treatment of blood disorders and cancers, with clinical interest in hematologic malignancies, solid tumors, and emerging targeted therapies. Dr. Dragan is deeply committed to delivering evidence-based, compassionate, patient-centered cancer care to the diverse communities here in the South Bay. Outside the hospital, Dr. Dragan enjoys scuba diving, reading fantasy novels, and spending time with his young daughter. This evening, Dr. Dragan will discuss skin cancer awareness, including risk factors, early detection, and the importance of recognizing changes in your skin before they become more serious. So, Dr. Dragan, the floor is yours.
Hello, everyone. So, as introduced, I'm Dr. Dragan. I'm one of our new oncologists here at the Hunt Cancer Center. And we're going to be talking about skin cancer today. Luckily, we've already had a little bit of an introduction, so I'm going to skip over that. Now, we're going to start with a little bit of a broad overview, and we're going to particularly discuss the 3 most common kinds of skin cancer today: basal cell carcinoma, squamous cell carcinoma, and melanoma. There are other rarer kinds of skin cancer that we're not going to really cover as part of our talk today. Let's start with a little bit of an anatomic diagram of the layers of the skin. Skin cancers arise really from the epidermis. So the top layer of the skin there, from different kinds of cells. Keratinocytes, which are really the origin of squamous cell carcinomas. Let's try that laser pointer. The basal layer, so basal cells, and melanocytes, which sit in a similar area. So basal cell carcinoma. This is going to be your most common subtype of skin cancer. And it's actually the most common type of cancer we diagnose in all individuals. It has an incidence of about 300 per 100,000 person years. And it's estimated that about 1 in 5 individuals will be diagnosed with basal cell carcinoma in their lifetime. The incidence of basal cell carcinoma is also increased depending on geographic region. So we see an increase in not only this cancer, but really all of the different skin cancers in sunny regions, so our nice California, but also the South and other areas throughout the world. We also see an increased incidence with increasing age, which is similar for a lot of cancers across the board. Now, there are a lot of different risk factors that can lead to the development of basal cell carcinoma. But one of the main ones that's true for all of the skin cancers we're discussing today is sun exposure. Now, they do have different patterns of sun exposure risk. So basal cell carcinoma and melanoma, to some extent, do have an association with sun exposure at a young age. So childhood, adolescence, not necessarily cumulative sun exposure. So we also see an increased incidence with very intense sun exposure episodes. So not as much for individuals who have chronic low intensity sun exposure. Along with sun exposure, very similarly, UV radiation from tanning beds can increase its risk. And a handful of others listed here, such as ionizing radiation, which can be from treatment for a variety of different ailments. Fair skin is an increased risk for all of these different skin cancers today. Fair skin, light hair, light eyes all have an increased risk. Now, chronic immunosuppression from either medications, illnesses, or otherwise can also increase a risk of basal cell carcinoma development. Now, 70% of basal cell carcinomas arise on the face. Another 15% or so can be found on the trunk, so the chest or the back. And the majority would appear as this kind of type. This is called a papular or nodular type of basal cell carcinoma. They can also appear in other ways, a very kind of superficial spreading here in the lower image. That's a rare subtype in a minority of individuals. Now, the treatment of basal cell carcinoma for most individuals is going to revolve around surgery. Surgery is usually accomplished by dermatologists, and so I'm not going to go too much into treatments and things outside of my specialty necessarily. But in addition to the use of surgery, things like various medications can be used, especially if it's an advanced disease, or radiation if surgery is not an option for individuals. Now, luckily, basal cell carcinoma does have a very low rate of advanced disease on diagnosis. It's somewhere around 0.05% of cases of basal cell carcinoma present with metastatic disease or advanced disease. Our next cancer is squamous cell carcinoma. So this is a bit rarer than basal cell carcinoma, has an incidence rate of somewhere around 60 per 100,000 patient years. It does share a handful of similar risk factors, one of the main ones being sun exposure. But squamous cell carcinoma is a bit different, where it's more about cumulative sun exposure risk. So individuals who are out in the sun for their job or hobbies throughout the day and for many hours are going to be at higher risk for the development. Other shared risks with basal cell carcinoma are the fair skin and irradiation. But a couple of particulars. Number one, chronic inflammation. So individuals who have a history of burns or other chronic inflammation of the skin can develop squamous cell carcinoma at those areas. The risk of immunosuppression is also a lot more pronounced, where squamous cell carcinomas are significantly more common in individuals with significant immunosuppression. So, for example, patients who are after a solid organ transplant, liver, kidney transplant, have a 200-fold risk of developing squamous cell carcinoma during their lifetimes. So all other diseases that can cause immunosuppression or medications can have similar risks. In addition, apart from immunosuppressive medications, there are other medications that will have a particular risk for causing squamous cell carcinoma. Some of them being also drugs that we use for treatment of cancers. But one that I want to bring to the public's knowledge is actually a very common type of blood pressure medication. So there's a kind of blood pressure medication called thiazide diuretics, one of the common ones being hydrochlorothiazide. Technically, these can increase sensitivity to the sun, and we do know that it can increase the risk of developing squamous cell carcinoma. So it is a very commonly used blood pressure medication. The clinical features for a squamous cell carcinoma, as you see, so there are a lot more variabilities in the presentation, where they can be a bit nodular, as we see at the top. They can be ulcerated. So a variety of different clinical presentations for that. Now, treatment, again, will rely mostly on surgery or localized destruction of the lesions. There are cryotherapies and others that are localized treatments, also usually performed by dermatologists. Generally, radiation is used when localized treatments such as surgery or others aren't feasible, and there are a variety of medications that can be used for treatment. In particular, the rates of metastatic disease are a bit higher with squamous cell carcinoma. It's still single-digit percentages, but somewhere around 3 to 5% of individuals can present with more advanced cancer, where it has already spread to localized lymph nodes or elsewhere, and that's really where a lot of times medical oncologists step in with either immunotherapy or other treatments. And then melanoma. So melanoma, luckily, is rarer than either of the previous two skin cancers we're discussing, with an incidence closer to about 30 per 100,000 patient years. Again, a big geographic difference in the incidence, where in particular the rates of melanoma development in, say, Australia are much higher than other parts of the world. That's also why Australia has a lot of research into melanoma. So as far as risk factors, as I said earlier, this shares a very similar sun exposure risk as basal cell carcinoma, but other risks are, say, having multiple moles. The majority of melanomas do not arise from benign moles, but about 1/3 of cases of melanoma do arise from benign nevi or moles. In addition, fair skin has a more pronounced risk factor for melanoma, where Black individuals have a much lower risk for the development of melanoma. And of course, a personal or even family history can increase your risk. Now, for clinical features, we usually educate patients about the ABCDE rule, standing for asymmetry. So if you have a mole that has an asymmetric pattern, that's a bit of a risk. Same with an irregular border, changes in the color throughout the mole, a very large diameter, or the E stands for evolution. So if you see a mole on your skin that's changing progressively over time, that's something to seek care for and ask your doctor for further evaluation. Okay? Now, treatment for melanoma is going to be a lot more varied, really based upon the stage, because a lot more cases will be found in more advanced disease in comparison to basal cell carcinoma or squamous cell carcinoma. So the full treatment discussion of melanoma is a bit outside of the scope of today's discussion, but I do want to at least bring up a little bit of what's more common in our specialty. And so the treatment of very advanced melanoma. This is something that we've made great advances in oncology in only the last 20 years. So this kind of graph is called a Kaplan-Meier curve, and it's how we regularly present survival for patients with cancer. The top curve here is nowadays. This is a modern survival curve for individuals with advanced melanoma. We see on the bottom here, this is measured in years, and our current 5-year survivals are more than 50%. That's in comparison to a median survival of less than 1 year only 20 years ago. A lot of that really comes about from advances in immunotherapy, for which Nobel Prizes were won for 8 years ago. Targeted treatments, there's a variety of different advances we've made, and we really see the difference in cases like advanced melanoma. So let's move on to sunscreen, because that's a lot of basics about these different kinds of cancer. So at least some basics about sunscreen application. These are things that personally I didn't even know until my wife taught me. So applying 15 minutes before you go out in the sun, reapply regularly, definitely reapply after swimming, even if you are using water-resistant sunscreens. Now, one handy-dandy tool to remember how much sunscreen to place on your body is the teaspoon rule, and essentially 1 teaspoon for all of these various different areas marked here. So the American Academy of Dermatology recommends using at least SPF 30, and that's because even though SPF 15 does block still the vast majority of UVB rays, most individuals are not using sunscreen properly or liberally enough, and so they recommend using at least SPF 30 to kind of cover that gap. Now, as far as SPF, So number one, what is SPF? It's a measure of it's a ratio of how much longer your skin is protected with the use of this sunscreen. So if your skin would burn in 1 minute of sun exposure, if it's unprotected, using an SPF 15 on that area would protect it for 15 times as long. SPF 30 being 30 times, and as it goes up. Now, one common myth that we hear about is that, there's no reason to use SPF above 30 or so, right? I don't know if anyone else has heard that myth. But where it comes from is that even SPF 15 already blocks around 93% of UVB rays. As you go up, the absolute difference starts decreasing, where SPF 15 is about 93% of this UVB rays, SPF 30 is closer to about 96, SPF 50 about 98. So you see it's a decreasing percentage of UVB rays it's blocking, but the relative difference is still always about twice as much benefit as the lower SPF. So that's where I think that myth really comes from. Now, speaking about UV rays, so SPF also specifically only measures protection against UVB. And UVB is only about 5% of the solar radiation that we receive. The vast majority actually comes from UVA rays. Importantly, UVB rays are what cause sunburn. They do play a role in the development of skin cancers, but in addition, UVA rays also have some role in the development of skin cancers and particularly a lot of age-related changes. So when it comes to blocking these different kinds of UV radiation, importantly, there are some differences in how the US versus Europe will label their sunscreens, and we'll get into that. So another big topic is safety. So when it comes to the safety of sunscreens, I would say inorganic filters have much more data about their safety. Inorganic filters are the ones that no one likes to use because they're going to be your grainy, they stay on the skin, they're going to be zinc oxide, titanium dioxide, these sunscreens that aren't as aesthetically pleasing. A lot of the easier to apply sunscreens are going to be your organic filters, but one little caveat here is that when it comes to sunscreens that we commonly use in the United States, they are considered over-the-counter drugs. And the US actually hasn't approved any new sunscreen filters since 1999. So the rest of the world does sell sunscreen from this century, and we do find that newer sunscreens generally do have a broader range of coverage. But most of these inorganic filters, like zinc oxide, titanium dioxide, do have a very broad UV range that they block. And of course, sun protective clothing is useful, and sun avoidance, the easiest one. Don't go out in the sun and you won't get UV ray exposure. And just to mention about FDA sunscreen labels, not all sunscreens are created equally. And so if your sunscreen specifically has this phrase, if used as directed with other sun protection measures, it decreases the risk of skin cancer and early aging caused by the sun. This can only be a label on broad range sunscreens that have some coverage in also the UVA range. They have to be at least SPF 15 too. If your sunscreen has this label, where it's just a warning that UV rays can increase the risk of skin cancer, that is not broad spectrum, nor it might be less than SPF 15. And importantly, water resistant is only 40 minutes, Very water resistant is 80 minutes, and there's no such thing as waterproof anymore. That's not allowed. So, we talked about the 3 most common types of skin cancer. Sun protection's key, as it's one of the most modifiable risk factors that individuals run into, and proper use of sunscreen is important to maximize its benefits. And here's a picture of my baby daughter with totally proper sunscreen protection, or sun protection, here on Redondo Beach. Thank you.
All right, thank you, Dr. Draga. We appreciate that, and what a lovely family you have. All right, now if you have any questions for Dr. Dragan again, we'll have Frank come around and our committee come around and take them from you, and we'll do it during our Q&A portion. Now, our second presenter, Dr. Vimal Murthy, joining us again tonight as presenting for our series. He is our general surgeon and burn specialist here at Torrance Memorial Medical Center, whom I have the privilege of working with every day in our burn ICU and alongside our burn outreach committee. A lifelong South Bay native, Dr. Murthy was born and raised in Manhattan Beach. He earned degrees in biochemistry and epidemiology in UCLA, received his medical degree from George Washington University, completed his general surgery residency at Indiana University Medical Center, and completed a prestigious burn surgery fellowship at the University of California, San Diego. Dr. Murthy is a fellow of the American College of Surgeons, a certified wound specialist, and has served on the medical staff at Torrance Memorial since 2003. He's played a pivotal role in helping Torrance Memorial Burn Center achieve verification by the American Burn Association, and remains actively involved in advancing burn care through research, innovation, and education. Here at Torrance Memorial, Dr. Murthy leads care of patients in the burn ICU and burn, wound, and amputation prevention clinic, where he treats patients with complex burn injuries, traumatic wounds, and limb-threatening conditions. He is especially passionate about restoring the lives of burn survivors, both physically and emotionally, and has a special place in his heart for caring for pediatric burn patients. Tonight, Dr. Murthy will help us better understand burns by explaining what happens during a sunburn, reviewing different types of burns, and discussing different degrees of burn severity. Drawing from decades of experience and caring for burn patients, he'll also share practical tips on burn prevention, early recognition, and when to seek specialized care. Outside of medicine, Dr. Murthy enjoys volleyball, basketball, go Lakers, scuba diving, a cappella singing, and an avid trivia enthusiast. In fact, his love of trivia even led him to compete as a contestant on Jeopardy. Now, ladies and gentlemen, Dr. Murthy.
Thank you for the intro, Tuscan. And, actually, as I come up here, I just realized for our audience in the Zoom, and, thankfully, for you all for joining, I just realized that it's not that the saturations just got turned up where there's like more pink and more color on the skin. It's actually a different guy. So in case you were wondering, it was just a function of the screen mechanics. Nope, different guy. And obviously, it's a pleasure to listen to Dr. Dragan, and hopefully his words have resonated. What I think, sort of, not to put words specifically in his mouth, but some of the things that he has educated us about is really more kind of a chronicity of sun exposure and sort of the pitfalls that can happen. I think what I'd like to do, at least for the few minutes we have, is to maybe focus on something that can happen a little bit more acutely that thankfully doesn't necessarily lead to malignancy or malignancy development, but nevertheless it's important enough as Tuscan has alluded to this being a burn center, this being the summer. I think it's still reasonable to kind of discuss these things. So I don't have anything to disclose other than I didn't pay him for those kind words, at least not where you people were watching it. So at any rate, let's just talk about sunburns. And it is not to insult or offend anybody here in the audience, but generally speaking, this is an entity that affects younger folks than us. And really, it's no dishonor on us. It's just that it's really sort of the tendency for people of youth to be in the sun for longer periods of time, okay? I mean, generally speaking, we're talking about it affects kids that are younger than 18. Hopefully, as you've already alluded to, your daughter is good for now. Keep up the rigor with keeping her protected. But all kidding aside, guys, the elderly population, look at it like this. You have in us where our skin is more fragile, we are going to be more susceptible to compromised skin than our younger population. So it's more curating a pathway of how you are being out in the sun, what precautions you take, because if you kind of think about the time component, with our skin that might be more fragile, there's more risk of having sunburn. So again, while it skews more toward a youthful demographic, the incidence is higher proportionally in the elderly. So just keep that in mind. So here's kind of a graph here, and it's somewhat interesting. I want to kind of not let you fall into a trap here. Ordinarily, you'd think, well, cool must be decreased amount of sunburn, and then it treks over to hottest. But in fact, that's the converse. Really what we see is an incidence of sunburn really more in the Gulf Coast states. And the etiology of that, it's not exactly well understood. It could just be, we have here in the West, we're accustomed to dealing with sun year-round, and so maybe we have a process that really is more strategically thought out vis-a-vis all of us are inside right now as opposed to being outside, right? So I think there's a little bit of a mindset that has helped that. Now, certainly, we will talk a little bit more about the pitfalls of hot contact burns where heated surfaces can lead to injury, but that'll come a little bit later. But yeah, in terms of the actual demographic, the geography is really more, in terms of the incidence, is actually more in the Gulf Coast. So what kinds of symptoms and signs do you have when you get a sunburn? Well, certain ones are pretty obvious. We tend to get red, right? And I will just say that it's a little bit easier to assess that in folks of lighter pigment than it is folks of darker pigment, right? I mean, I look at myself, and if I get sunburned, what is that like? Auburn. You have to pick a shade of something, and it's harder to describe. But certainly, in a population of lighter skin, the redness, or the fancy term for those of you that want, we call it erythroderma. What does that mean? Red skin. But at any rate, it's easier to observe in a population of a lighter skin complexion. Then there's certainly some other sort of subjective feelings. Your skin may feel tight. It may actually feel warm. And then, no question, pain is in play because some of those nerve fibers get compromised, and they themselves can lead to very challenging ways of how to manage the sensitivity. Swelling, particularly in, say, extremities, that word, perhaps y'all are familiar with edema, that's essentially what that refers to. And then ultimately, you can actually get what we call desquamation, and I'll show some slides of what that looks like. That is essentially the skin kind of peeling. So in terms of other things to watch, I kind of showed you what you could see at the local, or what we'll just call the skin level, the redness, the pain, the skin sloughing, et cetera. But there's also going to be some what we call sort of more general symptoms or physiologic things to be paying attention of. And it could be, you get a little fatigued, you may have some higher temperatures. These are going to be things that are actually going to be a little bit more of a red flag for something more advanced. So it's one thing to have redness of the skin, but if a patient is presenting with these other things, that could be a little bit more ominous. And then really, if you really have someone who's exposed to a hot temperature, I think we're all hearing about the challenges that Europe is dealing with. And this, I don't know, this seems to be a recurring theme with those guys out there. Every year we hear about, hundreds, if not thousands of people that are succumbing to outside heat. And so the trick with that is that sometimes that's accompanied by dehydration. So what happens when you get dehydrated? Well, not only can you get just exhausted, you get rapid breathing, which that term is called tachypnea, and then you start sort of having mental status clarities issues, so things like confusion. So these are really sort of advanced signs, and that patient is almost assuredly going to need to get some degree of medical treatment. So, here's kind of a classic distribution of a sunburn. You could kind of see that this person would have worn a top that conferred protection, particularly in the straps that go sort of posteriorly, go over the shoulder blades onto the clavicles, anteriorly presumably, and that's a very sort of kind of pathognomonic for a sunburn. You can see that which is protected does not have that erythroderma appearance. That which was exposed does. I just wanted to include this because this person is probably a fan of the NFL. Note the goal post distribution. I'm not exactly sure what kind of clothing would have led to this. Maybe this was some kind of TikTok or YouTube experiment of how I can stencil a goalpost in. But all kidding aside, I do want you to call attention to, so for example, the inside of this person's left arm is relatively free of that erythroderma. So chances are that person, while they were unfortunately getting skin compromise in the other parts, they may have been just tending to hold their left arm sort of within the ability to protect that part. So it's pretty classic where if it's exposed, then you're going to get that erythroderma, the redness. If not, then it's going to tend to get protected. Here's another one that I wanted to bring. I don't know, this guy could be like one of the Norway World Cup supporters or something, but I'll actually tell you, and I don't know if you guys are either old enough to remember, or speaking of my being a trivia nerd, for those of you that were fans of the Brat Pack movies in the 80s, I swear this guy looks like Anthony Michael Hall. He of 16 Candles, Breakfast Club, etc. So very, very, it's not him, I don't think. But at any rate, you can sort of see, like I said, it's all about shielding, less effective at shielding the face and the arms, and then more appropriate shielding elsewhere. So these are just sort of, some distributions. But I think we've all seen the appearances, and dare I say, we might have all experienced this appearance. So it's how you strategically protect yourself. Okay, so these are just, again, sort of the manifestations and the stages of sunburn. I mean, everything is on a spectrum, right? Your skin may have compromise, or it's just where on the spectrum, what's the trajectory? The redness is a thing, the pain we talked about. I'll show you some pictures later of some blistering, and then again, peeling, what we call desquamation. So ideally, though, the peeling of the skin does wind up inducing healthier skin underneath. So to Dr. Dragan's point about the potential repetitive exposure can lead to some kind of issues and risks of malignancy, that is not typically something that we would see for these sort of more truncated exposures to sunburn. But again, we certainly are aware that some of the burned skin in patients can be a predisposition to the development of skin tumors. But full disclosure, in whatever 22 years of doing this, I don't think I've actually seen one happen but for in a textbook on burn surgery. So not discounting it, but at the same time, statistically, it's still a relatively low observation in our practice. So I'll also echo some of the presentations that he did from what we call a microscopic or histologic standpoint. You have ultraviolet light that is sort of beating down upon us, and then there's certain skin types that you kind of alluded to that called melanocytes. Melanocytes are responsible for producing melanin. Melanin is essentially a pigment that helps sort of a buffer to mitigate against ultraviolet damage. And so what happens though is that, again, folks of lighter pigment have less melanin, folks of darker pigment have more. That of course is sort of an evolutionary trait. So for example, peoples who were or grew up at the equator are going to have more melanin than, say, people at the polars. So Nordic people, by definition, are going to have less melanin just from a genetic standpoint than equatorial people. And what does that mean practically? Well, if you have more melanin, statistically, you're more likely to have that buffer, and you potentially are going to be able to sort of ameliorate any further compromise. But again, that's only a finite thing. So that's not to say that it completely blocks out any kind of solar damage. So, and again, we'll talk about some of these things sort of at the conclusion, because I do want to discuss a little bit about some of the depth of burns that go just deeper than what we're really talking about. But here you kind of have a schematic of the principal tissues that define our skin. The upper part, that's our epidermis. That's what kind of makes us us. And then below that, there's something called the dermis. The dermis is really the strength of the skin. That's what sort of, as we age, that's where some of the elements get more and more attenuated, and that leads to thinner skin, more susceptible to trauma, et cetera. And then below the epidermis is called, you could say the term hypodermis. Another term would be subcutaneous tissues. So these sort of three layers will define how we collectively manage burns. And then sort of the definitions would be, first degree would be a burn or a thermal compromise into the epidermis, but not necessarily into the dermis. Then you have a second degree burn that goes into the dermis, but doesn't necessarily penetrate it. And then lastly, you'll have a third degree burn that really traverses all of the relevant levels. And certainly Tuscan, as he's fielding calls from outside facilities or as helping to assess burn patients in our own ER, he's going to have to make intelligent, relevant discussions and with those care providers in terms of how to manage those kinds of patients based on our best ability to assess depth of injury. So again, this is sort of just a recapitulation of some of the things that we talked about before, the depth of burn related to the epidermis, the dermis, and then again, below that, we call this the hypodermis or muscle. If you want to call it the subcutaneous tissues, that's fine. And just think of it as you can only bank so much melanin. Whatever amount that your melanocytes are producing, there's that, we'll call it reservoir, and as your UV light is sort of, or as UV light is streaming upon you, it's going to try to, your melanin reservoir is going to try to be effective as possible, but again, it, for the most part, might be finite. And so what happens is if the UV exposure exceeds what you can provide, then that becomes sort of the area of tissue compromise, be it leading to malignancy development or something more acute. So when we are sort of confronted with these kinds of either admissions or trying to give medical advice to our colleagues elsewhere, these are the kinds of things that Tuscan and the crew are going to be asking. They're going to want to know what's the patient's medical history, the symptoms that we talked about, the medications that you're taking. Again, I think Dr. Dragan referenced thiazide, for example. So these kinds of things are potentially relevant in terms of how you potentially manage that patient or what other things that could exacerbate their condition, a family history, any kind of genetic predisposition, and then certainly any recent exposure to anything that could be irritating or allergic. I wanted to sort of include some things that sort of could mimic sunburn, but are not necessarily cut from the same cloth. There's something that we kind of call a purpura or senile purpura. That's essentially as we age. I used to say the older we get, now I say the wiser we get. You get sometimes attenuation in certain areas of the skin, and then let's just say that as oftentimes we age, there may be a predilection to be on blood thinners for whatever reason. Your blood kind of is more like Kool-Aid, if you will, less likely to clot. So any innocuous trauma, while that was a bruise when we were younger, can become something that remains in place a little bit longer. These also tend to appear on like the extremities because of things like trauma. You also may have some other manifestations of skin damage, again, kind of the chronic nature of exposure that Dr. Dragan had educated us about. Generally speaking, though, these are going to be relatively benign. In the absence of new trauma, generally these can get better. So I do kind of caution folks that sometimes it's like playing whack-a-mole, right? Where if somebody comes in with some kind of trauma or some kind of purpuric wound, we'll just call it a purpuric break in the skin, then like while that could heal, you're always sort of on bated breath, making sure that there's no others elsewhere as that person may sustain repetitive trauma. Then here's something a little bit more nuanced but nevertheless could sort of be equated to a sunburn. You might have heard of something called celiac disease. Celiac disease is principally a disease of the gastrointestinal tract, but it in and of itself can have what we call cutaneous manifestations. It can give you kind of like some itchiness, some blisters. What you really have to kind of diagnose it with, even sometimes biopsy. There's certain blood tests that can also help codify that diagnosis. The treatments, though, are really more sort of systemic. They can be with diet modification. But again, we'll sort of talk about some of the myriad of different kinds of just remedies they can use for symptomatic relief. But I just wanted to kind of bring this into play in terms of something that may look like sunburn. Then there's what we call a dermatitis. Dermatitis, derm for skin, itis for inflammation. So you have an inflammation of the skin. Atopic dermatitis is essentially what we would term eczema. That's where really it's not necessarily a defined exposure, but sometimes your immune system can just lead to chronic, irritated, inflamed skin. And then contact dermatitis would be things like exposure to those different irritants, poison ivy, poison oak, something that just may mechanically irritate your skin. These can also sort of mimic sunburn. And then I just wanted to bring this to your folks' attention. Tuscan mentioned that there is a wound center here at Torrance Memorial, and so oftentimes there'll be patients with circulation issues. Sometimes your veins over time can get chronically inefficient, and those skin changes can mimic sunburn, not necessarily, though, of the same etiology. So, how do you test for sunburn? Well, again, mostly it's clinical. Someone tells you that they were out in the sun, right? I mean, it's not there's no smoking gun to that one. But again, you do want to make sure that you've done a good job getting a history and physical, and it's a temporal component, right? If somebody tells us that they were out and about, okay, how long were you there? What exposure, either precautions or lack thereof, were being taken. And then again, kind of as I talked about earlier with the heat stroke and more signs of or worrisome for dehydration, you're going to want to check things like serum chemistries. You're looking to see if a patient's kidney issues might be in play in terms of compromise because of some kind of associated dehydration. I just wanted to kind of just remind folks that when you do get compromised skin, really of any cause, be it sun exposure or eczema or what have you. Well, we all have bacteria that live on our skin. I mean, we all do, and ordinarily they don't make mischief. Well, every so often at an unpredictable, untimed interval, they can. So if you have skin that in and of itself is sort of predisposed to get an infection, then sometimes we will check something called a white blood cell count that could sort of strengthen the concept of there being an infection there. And so how do you treat this sort of stuff? This is kind of like there's going to be a lot of different kinds of remedies. I think the biggest take-home lesson is when you're trying to treat sunburn at the level of the skin, nothing is standard. It's an awfully big world. There's a lot of different cultures. They're going to have their different sort of treatments and remedies. And one thing that, to the extent that we are the great American melting pot, it also is relevant because, as again, Tuscan and the crew field calls from patients or hospitals, we may hear that various different kinds of things have been tried. And like I said, there's, we heard a little bit about solar protection formula. We heard a little bit about different kinds of formulas. It's like, I'm just getting warmed up because there's lots of different stuff that you hear about that is out there. So I will say, though, that in sincerity, that aloe vera, for those of you that are sort of more beholden to, we'll just say, naturopathic or sort of holistic remedies, aloe is something that has really kind of stayed the test of time. We sort of jokingly tell people an aloe plant in every house, because if you get some kind of acute thermal injury, be it like a cooking scald or whatnot, just break one of those leaves off and then rub the juice on, because it's shown even at the microscopic level that some of the components of the aloe actually help sort of mitigate against inflammation. So for those of you that if you guys really like sort of more natural strategies, aloe's a big plus for us. So, and there's things like topical, even oatmeal. You could use green tea, moisturizer we talked about. The hydration part is really important. Less so for the actual skin part, but you really want to make sure that you're not having some of the systemic compromise. You don't want the patient to be dehydrated. You don't want them to get mental status changes, et cetera, et cetera. You don't want them to get kidney compromise. So, again, more of the same. Shea butter this, emu oil there, different kinds of topicals. You can use Tylenol, Advil, lots of water. Again, this says creative sunburn remedy, so creative. So tea, cucumbers, baking soda, yogurt, oatmeal. Yeah, it's, again, like I said, the world's an awfully big place, so there's lots of different ways to try to treat things. Again, if there was something that were universally effective, then that would be the only thing. So I think it's fair to say that there's different places for each of these, and they may very well fill certain niches depending on what your preference is. And more do-it-yourself stuff, honey and instant oatmeal. Man, that sounds delicious. You could take a tube sock with oatmeal. Man, who would do that? Okay, all right. Well, no judgment. But organic coconut oil. So I will tell you that as a child born of family from India, coconut oil used to be what mom used to put on my hair to comb it, and who thought that decades later it's like, oh, I guess should do that for sunburn. So sadly, as you could tell, it may not have worked, but we probably still have some of the oils somewhere sitting around. And you should kind of want to show you is a little bit more about the advance. So here's some of the little bit of blistering, and then this is that desquamation that happens over time. Ideally, though, the difference is that this is going to be principally healed. Now, here's where it gets a little bit more, and I guess I should have a disclaimer for those of you that may not be, or maybe of the faint of heart. I don't think there's too much gross stuff, but if so, I apologize. It is what we do for a living, though. But anyway, you can kind of see that erythroderma, it's got to be painful as all giddy up, and then here it's already coalesced into something with a blister, and that's going to almost assuredly need to be unroofed and dressed with some kind of topical ointment. more of the same. And I think, yeah, and so this is, I think, what Dr. Dragan had alluded to before is that, well, there's this very sort of pasty stuff that you can kind of see. So this is obviously a well-intended person's attempt to help with this poor kid's burn. But yeah, I mean, again, thankfully, these burns don't necessarily go on to need surgical treatment, but one can only imagine how painful they could be, right? And so kind of the last thing I want to just talk about is we'd already kind of delineated the different depths of burns and how they're relevant in terms of which layer of tissue they are that they land in. So again, it being the summer, right? There's the potential for contact burns, basically on a surface, on a heated surface, on a pavement, you name it. And these things can really be devastating, mainly because of that's the part where someone could be sort of found down. And dare I say, sometimes medications, be it prescription or otherwise, are often involved. And so that person who might be legitimately immobile on a hot surface, and I think, for those of you that are, football fans, whatever, right? They always have that heat index, right? When it's on the surface of the field, and it's exponentially higher temperature than what is in the ambient atmosphere. But imagine laying on that for X amount of time. So what do we see? Yeah, this more lands in places like Vegas or Arizona, but really at this time of year, it's kind of year round. So here's where you're going to see more, a little bit more pronounced. So these are what we call plantar foot burns, or the soles of our feet. Palms of our hands, soles of our feet have the thickest skin, so theoretically they're the most resistant to thermal injury. But you can probably tell over time this really created some problems for this patient. I think I got one more slide. That one doesn't really. That image is kind of grainy, but this is one where this is actually like the side of this patient's left leg. So presumably they were found down, and this is the term we use is S-scar. It's just another fancy term for burn, but that's unquestionably going to need to have surgical treatment somehow. So again, this time of year, you have to be very mindful about this. And so just to kind of wrap my part up. So this is a thing, right? I mean, but at least, thankfully, other than pain, you don't have a lot of major symptoms. Again, that assumes that people are adequately hydrated. But I think where it speaks to is that the repetition, sun still rises, so you know that you can't just keep people inside. And whether or not it leads to things like Dr. Dragan alluded to about risk for developing malignancies, that is something of relevance. But yeah, how you treat it, you just focus on symptoms, pain relief, try to help soothe the patient, and then there may be some issues of skin changes down the road in terms of how it appears. But again, really, that's still less of a problem. But when you get these contact burns, they can be very problematic. So I think that's all I had. This is my mother, and I just want to take a moment, if I may. So just today, Mercy, who was just texted me out of the blue saying, "Hey, Doc, can I come to this thing tonight?" I've heard from Mercy periodically. Mercy was one of, God bless her. She helped take care of Mom, in her last, few months. So thank you very much for coming. And again, I thank you, and happy to take any questions through Tuscan or Dr. Dragan.
All right, thank you, Dr. Murthy. Now let's give Dr. Dragan and Dr. Murthy another round of applause for sharing their expertise with us this evening. All right, now at this time, we're going to transition to our question and answer portion. Frank, I know Mary told me Frank has the mic. I do hope tonight's presentations have provided everyone here with valuable information about protecting your skin and preventing burn injuries. So what we'll do is I will man our virtual Q&A over here. If anyone has any questions that they would like to submit to Dr. Dragan or Dr. Murthy, please raise your hand and Frank will come towards you.
Okay, here we go.
Is skin disease hereditary?
Can you say that one more time?
Is skin disease, is it hereditary?
Oh, is skin disease hereditary?
If you mean about skin cancer, then yes, particularly melanoma can have an increased risk if you have a strong family history, but there are a variety of genetic or inborn genetic syndromes that can increase the risk of the other skin cancers too. They can be quite rare, and so it's not that everyone who has a family history of skin cancer will always develop skin cancer, but things like albinism, which is an inherited condition, can also increase the risk of skin cancer.
Anybody else? Here we go.
Okay. I was using hydroquinone skin bleaching cream for 4 or 5 years, 20 years ago. And it took 2 or 3 years by the time spots were removed. And then they discontinued it, I understand, and the doctor said, get off of that, because they found cancer in rats. Can you recommend anything like hydroquinone, something that works?
I don't think I can confidently answer that. So as a medical oncologist, we don't generally deal with various different skin creams or other things to treat kind of skin ailments. So it's a little bit outside of me being able to answer. Sorry.
Frank, before you go on to the next one, I do have a question for Dr. Murthy here. For home remedies, we've all heard of recommendations like butter, toothpaste, or ice on burns. Can you help separate fact from fiction?
Kinda. I mean, you don't begrudge a well-intended person for trying something. I do think, though, that if I were to sort of plant my flag on a naturopathic, holistic strategy that would be best, I would plant it on aloe. So I think we certainly don't advocate the things like butter and mayonnaise and toothpaste and peanut butter and lettuce, like all these things that you hear about. But also, we're also sensitive enough to know that there's some cultural components that are hard to, I guess, unchisel. So it's a fair question. That's how I would best answer it.
Thank you. Sounds like a good sandwich, though. Thank you, Frank.
Question, I'm a diabetic, and I'm wondering, especially this new medicine, Mounjaro, has some effects on your skin?
Again, I don't think I can confidently answer because it's also not a medication that I would normally prescribe. Mounjaro and a lot of these medications really became popular after I was an internist years ago. So I don't know all of the necessary details or the full risk profiles of them, simply because it's not something that I would normally prescribe for individuals.
Relative to thiazides, the photomatic effect, is there equivalent things for ACT that you can replace ACT with something that doesn't have thiazide in it that's less photochromatic?
There's a variety of other hypertension medications that are also considered for first-line management. Things like ACE inhibitors in certain individuals, which do not share the same risk of photosensitivity.
I don't know if you can explain or elaborate more on if you had really bad sunburns as a child, how much that affects you as an adult. Is there, I don't know, it's just too late to do anything about what happened I was from the Jersey Shore, and we would, in the 70s, we would literally burn on purpose and peel on purpose. Yeah, really? Yeah, baby oil.
Without making this personal, do you mind sharing like what symptoms long term or what signs you think you've had as a result of repetitive exposure? Maybe that would sort of help how we would answer that question.
When I go to the dermatologist, they burn off something almost every time I go. So it was once a year, now it's every 6 months. But nothing super serious. Just always burning things off.
I don't mean to sound too folksy, but you know, like at some point we get to enjoy the sun. Now perhaps you being on a spectrum has more appointments with a dermatologist than the rest of us that enjoy the sun. But I do think that you know, everything being sort of on a curve, I'm trying to think if there's things that really toughen up your skin. And I don't know that we've really demonstrated, okay, if you take someone who's had more of a initial exposure to sunlight and then perhaps they curate a pathway that they're less exposed, I don't know that you develop more melanin. I too, not my wheelhouse either. Sorry.
Yeah, I would comment that, yeah, I agree. We don't really have data about suddenly exposing yourself less would reduce your risks, but this is something that I commonly run across in oncology of what if I did this, or really looking back at the past. And it's something I always say it's important not to, because there's always different decisions that people have made, and there's so many things out there that we learn can increase the risk of a variety of different cancers. So the important things are, what can you do moving forward? And that is actively altering all of these variety of different risk factors. And yes, anyone who's at high risk for the development of skin cancer from one reason or another, skin cancer screening on an annual basis with either your primary care physician or a dermatologist is recommended for high-risk individuals.
Good evening. My question is about skin elasticity. There's so many different ways that happens to people. I just wonder what the sun effects are on that, if it has any effect on our elasticity of our skin.
So kind of age-related changes to skin elasticity are primarily driven, as I mentioned, by the UVA rays. So that's going to be different than what the majority of sunblocks actually block against. So that's why it's also really important for broad spectrum sunscreens, since those can help prevent these age-related changes mostly.
And then don't forget there's a age-related, just organic decrease in the tensile strength of our skin over time anyway. So in theory, that person who may have had a very modest exposure to sunlight will still be having those kind of what we call atrophic, or just sort of like thinner skin, if you will. So there's always going to be a baked-in component of the natural aging process.
Good evening, I'm Mercy. I want to ask, is it necessary to cleanse my face morning, every day like that? Morning and evening. Is it necessary to cleanse every day?
You're referring to, are you worried about like getting, I guess, your pores blocked? What is your concern?
Because when my mom is still alive, she always telling me, don't wash your face in the morning because I think it's sebum.
Mercy, if mom said it, please go with that. You know, like let's.
Yeah, in the morning.
I do not want to. You know, that's not what a power I want to go against.
Yeah, Mama's always right, Mercy. So
But I always rinse my face in the morning. But because her skin, her face, glowing.
I think the question is, should just doing it twice a day, would it
Yeah,
affect
twice a day or
anything
thrice
with
a day.
with her
Is
pores
it
or her skin?
necessary?
I mean, it might be just you might be able to get by with once a day. I sometimes I think that, and you know, maybe Dr. Raga, neither of us are dermatology folk. Again, full disclosure about that. But I'm led to believe that the more frequently we wash just really any body part, it kind of tends to dry out. So there is sort of maybe a diminishing return about that.
So while Frank makes his way to the back, for both of you, at what point should someone stop treating a burn at home and seek emergency medical attention?
So can you hear me? Yeah, sorry. Great question. There are certain kind of signs and symptoms that are associated with what we talked about with the sunburn. So if your pain is not well controlled, if you wind up with blistering, if you have other sort of systemic symptoms, the fevers, the confusion, et cetera, that should absolutely seek medical attention. This is one of 3 burn centers in all of Los Angeles County, so Tuscan and the crew are quite expert at being able to field these calls and potentially route people to the appropriate destination of care. But I think burns in general, you have a low threshold of managing them on your own. There are burn clinics, though, that can be funneled into on an outpatient setting, though.
I have an unusual question. I have a small burn I got years ago on my wrist that came from the inside, not the outside. And it was so strong, I had to go to the sink and run cold water on it. And to this day, every once in a while, you can feel it. Every once in a while, I get like a white scab that forms. I was sitting on the bed watching television, and all of a sudden it got hot and hotter and hotter and hotter. Very strange, and I'm just wondering if there's something I should be concerned about.
I mean, to the extent that I haven't happened to have observed that before, like an internal burn leading to an external manifestation, it might be something else like a cyst or an abscess or something like that. Yeah. I wouldn't know. There's nothing I could think of that resonates with me other than monitoring it. If you get a break in the skin, you would put some ointment on it, hopefully until it heals, and just go from there.
Are UV rays more dangerous in the fog? More dangerous than in a sunny day?
Well, it depends upon the time of the day, right? Where, of course, in the middle of the day, you're going to have a stronger UV index. Generally, cloudy days can scatter the UV rays to some extent, but it does not fully mitigate and does not fully prevent UV rays from kind of penetrating through to someone.
I was wondering, I don't know if this is a question I can direct to you, but treatments for squamous cell cancers, what sort of treatments are there available, and what are things that you recommend or that would be recommended, especially on legs and things?
So the majority of localized treatment, so localized destruction with, as I said, cryotherapy, surgeries, things like that are performed by dermatologists. So as a medical oncologist, that's generally something that we don't go into, so I wouldn't be able to confidently say what would be more appropriate in your case or for different parts of the body. Times when a medical oncologist would be involved in the care of squamous cell carcinoma would be if it were advanced enough that's involving lymph nodes. There are medications, even immunotherapy, that we would use as part of treatment in order to start shrinking it and to help facilitate surgery. Or there are even times where we'll utilize chemotherapy to prevent the development of skin cancer, like squamous cell carcinoma, in people who have developed a lot of skin cancer already and are aiming to prevent the development of further cancer. Say, for instance, I've personally had a patient before who had undergone so many different surgeries on the face from a history of multiple recurrent skin cancers that we elected to start him on chemotherapy to prevent further surgeries, further disfigurement, and it was working well for him.
Okay, I have a question for both of you. If everyone in this room remembers just one thing from your presentation tonight, what would you want that message to be?
You could kick that one off.
I mean, I think the biggest topic today is about sun protection. So I think the important tidbits about sunscreen use, proper sunscreen use, broad spectrum sunscreen use, those are things that individuals can change on a daily basis. It is a lifestyle change that you can do to reduce your risk of developing skin cancers. And prevention is always better than treatment.
What he just said. And then also an aloe plant in every house. I think that's a very reasonable take-home lesson for what we were chatting about.
This is a question that may be a little bit unusual, but I have a long history of medicine. My grandfather, my father, my brother, my nephew, my wife, I'm not my wife, my daughter. And I still have difficulty because I used to lecture in bioethics. And there's such a discrepancy among physicians as to when to treat and when not to treat. How can we reduce the discrepancy so that the most appropriate treatment is made?
Do you mean specifically about different skin cancers?
In my particular case, I've had about 10 squamous and about 8 basal cells. I never had a melanoma, but since I constantly have to go for the incision to remove it, stuff like that, which I'm obviously ready to go, but I've wondered because so much of it is on the face, I don't like to have so much scar tissue, but I can't get a doctor that's willing to perform another method. So how do I do that?
So as far as differing opinions from different doctors, medicine's complicated, right? It's not one size fits all no matter what we talk about. And so, yes, different doctors will elect to treat you in different ways because every single presentation's different. So for as the question of how do you find a doctor that will treat you in a different manner, then I don't think anyone really takes or is affronted by a patient saying, I'm going to go seek a second opinion for a different manner of treating this. I've personally never been insulted by that. It is okay.
Sometimes I've been relieved. Yeah, yes, please seek somebody else's help. There's a reason why we call it practicing medicine, not perfecting it. So, yeah. But no, I think we collectively wish you well, because that's got to be a challenge.
I don't know who to go to.
Is there any particular sunscreen that you guys would recommend on the market?
My answer is probably not going to be as nuanced as Dr. Dragan's, but the answer is fundamentally no. I would just say we like unscented as opposed to scented. The scented stuff smells good, but sometimes they have perfumes and alcohols and they can dry the skin out. And then I certainly toil more in the space of over-the-counter things as opposed to prescription. So, but that's about as specific. I do make a distinction between scented preparations and unscented.
I think we have time for one or two more questions if anyone else has any. Speak now. We got one over here. No, go ahead. No, you can just say it to me. Okay. All right. What do you feel about UV protective clothing, or should you still use sunscreen under the protected clothing?
So UV protective clothing also has a variety of different ratings. They're rated by UPF. So higher ratings have more protection from UV rays. Understandably, UPF 50 is one of the highest ratings, and so underneath that, I wouldn't imagine needing a sunscreen. But clothing is also a lot more variable. If it's wet, if it's old and stretched out, depending on the color. So there's a lot more variability in its ability to protect you underneath it. So if it is something that maybe doesn't have a UPF rating, then you're going to be out in the sun in very intense rays, it doesn't hurt to put some sunscreen underneath that. But if you're using a very high UPF rating clothing, it's generally quite protective.
I will add that kind of be mindful, though, about just how form-fitting those clothes are. Because one thing that it's sort of subtle, but if you happen to have, like a well-protected thread or garment, but if it actually winds up being too form-fitting, then it's almost like you have the risk of having what amounts to a contact burn, right? Because you still want to be wearing something that's going to shield from the sun, but there's also that paradox of, well, if it's too tight, then you can also get almost like a conductive skin, burn. So pick something that has a good formula, but then you also might want to give it some thought as to just how occlusive those clothes are.
And one last question from the audience. We have one final one over there, Frank.
I have some skin issues, and I go to the dermatologist, and she always gives me a cream. But I thought the ointment is better for me. But she said, it's your choice. So which one will I choose? Ointment or cream?
This might be a question of semantics, but for me, I prefer creams only because in my practice, I find ointments are just a little on the thick side. So what the presumption is that you don't have any breaks in the skin and your doc is giving you something to put on. I prefer, I guess, something that pours rather than something that oozes. So if it's something that comes from a spigot that has some liquidity, I'll make the distinction. If that's sort of what you mean by a cream, then I do prefer that. Otherwise, if they're comparably thick, then they're comparably thick. But when I think of ointments, I think of something like, Neosporin, Polysporin, Aquaphor, things that are just a little bit on the thick side. So if you're not careful, you may block your pores and you wind up with little zits for your trouble.
All right, thank you, Frank. If there are any questions that weren't asked, please see our committee in the back and the end, and we can address them after our lecture. So as we conclude tonight's series, I'd like to thank our outstanding speakers again, Dr. Dragan and Dr. Murthy, for sharing their expertise and passion and commitment to our community. I'd also like to extend my sincere thanks to the Miracle of Living Series Committee, our staff, Frank, who wielded and fielded all your questions, and everyone behind the scenes who made this event possible. Again, special thank you to Mary back there. Again, I know you don't like the spotlight, but sometimes we got to shine it where it deserves to be. So thank you for your leadership and dedication and bringing the lecture series to our community. And most importantly, thank you to our audience. You guys were amazing to our panel. Thank you for taking time out tonight and spending it with us here at Torrance Memorial. I hope you guys feel a little more informed, a little more empowered, and better equipped to take care of yourselves and your loved ones. So now it's whether it's protecting it from the sun, preventing burn injuries, or early signs of skin cancer. Hope you guys learned something today and you share it with your family and friends. Here at Torrance Memorial, our commitment extends beyond caring for patients outside our hospital walls. So through these series, through our outreach programs, hopefully we can promote healthier lives for all of you. On behalf, again, of Torrance Memorial, Dr. Murthy and Dr. Dragan, thank you for joining us. Have a wonderful evening and see you and good night.